Dear colleagues, in the next few minutes I would like to present my PhD thesis titled Multimodal Treatment Strategies in Resectable Pancreatic Cancer. My name is Tamás Tölgyes, I work as a surgeon, and with my brilliant team our vision is to provide the most effective treatment to patients with pancreatic cancer, and our mission is to investigate the different therapeutic modalities in resectable pancreatic cancer. So I have two ongoing projects, both focusing on resectable pancreatic cancer. Regarding the first one, we compare two different therapeutic strategies, and in the second one, we investigate prognostic factors after surgery. The first project's title is Comparing the Effectiveness of Neoadjuvant Chemotherapy to Upfront Surgery in Resectable Pancreatic Cancer. I'm starting with some dismal information. Pancreatic cancer is the 11th most common cancer type and the 4th leading cause of cancer-related deaths, and it is expected to be the 3rd one soon. And unfortunately, less than 20% of the patients are eligible for resection at the time of the diagnosis. But what is resectable pancreatic cancer? To simplify that, when there is no distant metastasis and there is no vascular involvement, there's one exception, the vein infiltration is less than 180 degrees. So currently the standard of care is surgical intervention followed by adjuvant therapy. Unfortunately, half the patients do not receive adjuvant chemotherapy due to the patient's condition. And this fact played a key role in the idea of neoadjuvant setting, followed by surgical intervention and adjuvant therapy, and maybe in this way we can achieve better survival. And my aim is to investigating the effectiveness of neoadjuvant therapy in resectable pancreatic cancer. So the clinical question is, does neoadjuvant therapy decrease the rate of mortality compared to upfront surgery? I use the PICO framework. The population is resectable pancreatic cancer patients. The intervention is neoadjuvant therapy. The comparator is upfront surgery. And the primary outcomes are overall and disease-free survival. And the secondary outcomes are histologic and surgical results. And my hypothesis is neoadjuvant therapy is superior to primary surgery in resectable cases. So we conduct the systematic search in 3 databases last November, and we found more than 15,000 articles, and we include only 15 articles because we include only RCTs. And let's review our results. In the first plot, we analyzed the resection rate in resectable pancreatic cancer in context of neoadjuvant therapy versus upfront surgery. So we included 8 articles, more than only RCTs, more than 650 patients' data. The I-square was 21%, but the confidence interval is wider, so indicating low heterogeneity may be attributed to different chemotherapy regimens used. The poor relative risk is 0.86. Meaning patients with resectable pancreatic cancer receiving neoadjuvant therapy have a 14% lower chance of undergoing resection. It is clinically and significantly significant because currently the only curative treatment option is surgical intervention. So jump to the second plot. We examined the R0 resection rate in the context of neoadjuvant therapy versus upfront surgery. We analyzed seven publications, more than 530 patients' data. The heterogeneity was 0%, but the confidence interval was wide. So I think this is maybe attributed to the different chemotherapy regimens used and the difference in the baseline characteristics. And the poor relative risk was the opposite one, because it was 1.22, meaning the probability of achieving an R0 resection is 20% higher with neoadjuvant therapy. And this result is clinically and mathematically significant because the R0 resection is even more associated with survival. So the last one is the post-operative mortality in the context of neoadjuvant therapy and upfront surgery. So we include 6 RCTs, nearly 400 patient data. The I-square was 0%, but the range was, but the confidence interval was wide. So I think this may be attributed to the previous reasons. And the pooled relative risk was 0.91, meaning there is no difference between the 2 arms. And of course, it is neither clinically and statistically nor statistically significant. So, but we have some strengths and limitations of our analysis. So the strengths, we use the robust methodology to provide high quality evidence and conclusions. And we analyze a large sample size, and we include only RCTs, which is the highest level of evidence in medical science. But there are some limitations. So the different type of neoadjuvant and adjuvant treatments, which elevates the heterogeneity, and limited number of borderline patients are included. And in this case, currently the preferred treatment is neoadjuvant therapy. So jump to the preliminary conclusion. The first is there is no difference between the postoperative mortality. The second one is the resection rate is higher in upfront surgery. However, the opposite one in the R0 resection is higher in adjuvant therapy. So there is an implication for practice. So maybe patients with resectable pancreatic cancer with poor prognostic factors, neoadjuvant therapy can be considered. And implication for the research, further studies needed to identify factors which patient benefits most from neoadjuvant therapy or upfront surgery. So regarding the first project, we are in the risk of bias assessment phase, and we planned and we have an ongoing analysis regarding the survival data. In the second project title is investigating the effect of prognostic factors on overall survival following surgery in pancreatic cancer. So I would like to add one information to the background. Hungary has the highest incidence in Europe in pancreatic cancer and second highest worldwide. But due to the innovations in the decades in surgical and oncologic fields, we achieved significant survival in certain subgroups. So about my personal motivation, I had an opportunity to visit and Professor Buchler in Heidelberg. And since then, I recorded and followed all patients operated at our department. Currently, I have more than 400 patients' data. And my aim is to investigate the impact of prognostic factors on survival following pancreatic surgery. So I use the PFO framework. The clinical question is, do the prognostic factors have a significant association with survival? So the population is patients underwent pancreatic resection due to ductal adenocarcinoma, and the factors are histologic and surgical factors, and the outcomes are overall survival and disease-free survival. Our hypothesis is this factor has no effect on survival. To sum up, regarding the first project, the planned submission date in September 2025, and regarding second project, I hope we will finish it in the next summer. So I would like to finish my presentation with the words of Mark Twain: "The secret is to getting ahead is getting started." Thank you for your kind attention.
Thank you very much. Is there any question from the audience? How could we be the second the second country who has the most cases of pancreatic cancer?
Yeah, it's a good question. So, thank you for your question. So, it is a multifactorial disease. I think we can choose one factor. So, but I know another factor we are very good worldwide. It is the alcohol consumption, and this is the only factor I know. But I don't really know the exact answer for this question. But I think many factors play role in this pathogenesis.
Thank you.
Just not only unfortunately not only pancreatic cancer or the second, but we got the colorectal cancer. We are in the first and the second place by male and female in the world. So I don't think it's some common cause, but maybe.
I have a question about your first project. Do you think you have the data about the outcomes? What you measured very important. I was thinking about the fourth one, which is about the spread of the cancer because of the manual manipulation. So if you have, is it a secondary cancer? Is it higher in neoadjuvant therapy or with the adjuvant therapy?
Could you repeat the question? What was the first part? So
do you think you have a higher incidence of the second cancer because when you have the surgery, there is a manipulation, a mechanical manipulation when you can spread the first cancer cells basically throughout the bloodstream. So do you have data which is better to be against the spread?
So I don't think the most important part of this question is the manipulation. So I think the pancreatic cancer is not a homogeneous tumor. So we don't currently know which patient has a better response to the neoadjuvant therapy or which patient has micrometastasis in the liver. So I think that is not associated with the manipulation. Mm-hmm. So I think it is associated with a hidden metastasis or more aggressive tumor biology. So because we achieved an R0 resection, but we don't know is there any cells in the lung or in the liver, and after that we decreased with this huge operation, we decreased the level of the immune system, and it is a great environment to these cells, to these freeze tumor cells. I think that this is not associated with the manipulation.
Great answer.
Congratulations. I have two questions. The first is that what's your opinion if we give a neoadjuvant chemotherapy for the patient who can be operable? It can be a good predictor to see how the patient tolerates the chemotherapy because it can predict how the patient can tolerate the surgery. What's your opinion about this thing? That's my first. The second one, you mentioned that you are following the surgeries in your department and you have database. And I know that the topic is that resectable tumors, but we have the borderline resectable tumors, and we gave neoadjuvant chemotherapy for them. Do you have any data how many of these patients who are in borderline resectable and get neoadjuvant chemotherapy, how many patients can be in an operable status?
Yeah, thank you. So I just tried to find what was the first question.
The first question is that if they tolerate the neoadjuvant.
Okay. Yeah. So I just repeat myself. So currently we don't know which patient has a benefit from which therapy. So I'm not sure about. So if all patients undergo neoadjuvant therapy and we select this type of patients who has a stable disease or disease regression and undergo surgical intervention, I'm not sure about all patients. For all patients, this is the best way. So there are patients who absolutely. So I think further investigating need to find the answer of this question, because it is not a homogeneous tumor. So we have patients who. So this is currently in the guidelines. It is in resectable cases. The first choice is upfront surgery, and we don't have enough data. The other problem is the various types of chemotherapy, and we have excellent chemotherapies right now because we have FOLFIRINOX, for example. But the problem is with the FOLFIRINOX, it is very good in adjuvant and neoadjuvant setting, and in resectable cases. For the last RCTs, provided they reached very good survival rates in the upfront surgery with FOLFIRINOX.
But it's very hard for the patient to tolerate that type of a chemotherapy.
Yeah.
So sometimes the patient condition becomes
and other problem is so we are talking about good performance status patients who tolerate the FOLFIRINOX, for example, and our patients in my experience, so they are not the best, so they're moderate performance status, and after give chemotherapy with FOLFIRINOX, which has excellent results, and after surgical intervention, we lose a lot of patients, I think. And about the second question, just borderline as fast as I can. So I can't tell any exact data about that, but my experience, we have only few patients, or that is the problem. And the other thing, the problem is with this, and if there is some radiologist, so the problem is the follow-up and how to find which is viable tumor and which is a scar, and we can't find which one is it. So we see that typically in after an adjuvant therapy, we see that there is something there, but we don't know it is a tumor or is it a scar. So currently we give for a half a year or 6 months period, and if the patient has a stable disease, we go to the operation theater.
Thank you very much.